Assalamu alaikum everyone. My name is Dr. Anum Ehmad. I am third year resident of diagnostic radiology. And the topic that we are going to discuss today is the role of multimodality imaging in metabolic syndrome. So first off, we will start with the introduction. What is metabolic syndrome? Metabolic syndrome is the set of risk factors that is associated with the development of atherosclerotic cardiovascular diseases and type 2 diabetes mellitus, which further leads to liver, renal, neurological or gynecological dysfunction. So we follow National Cholesterol Education Program ATP criteria 3, which requires 3 out of 5 of these major risk factors to be present in a person for the diagnosis of metabolic syndrome. This includes abdominal obesity in men greater than 102 centimeters, in female greater than 88 centimeter. Impaired glucose tolerance or fasting glucose of greater than and equal to 100 milligrams per deciliter. Hypertriglyceridemia of greater than and equal to 150 milligrams per deciliters. Low level of HDL in men less than 40 and in female less than 50. And high blood pressure of greater than and equal to 130 by 88. There are also some minor risk factors that include sedentary lifestyle, smoking, postmenopausal status, etc. But these are of less significance as we follow the criteria, ATP criteria 3, which requires these 3 out of 5 major risk factors to be present in a person for the diagnosis. So the prevalence of metabolic syndrome is 20 to 25% globally. And according to 2011 to 2016 stats, its prevalence is 35% in United States. So given its global prevalence, diagnostic imaging plays an important role in diagnosis and surveillance of complications. It provides with various modalities that include CT and MRI, which helps in quantification of subcutaneous and visceral adipose tissue, ultrasonography, which helps in assessing steatosis and fibrosis via elastography. A nuclear study that includes PET and SPECT scan that helps in detecting insulin resistance and brown adipose tissue. Cardiac MRI that helps in evaluating structure and function of myocardium and helps in differentiating non-viability with ischemia. Then we have CT angiography, which helps in assessing coronary and systemic arteries. So what is the goal of metabolic syndrome? Its goal is early recognition of complications and minimizing those complications through lifestyle and targeted treatments. So this table takes you through the role of different modalities that we have already discussed. And here we have an overview of their strengths and limitations. So first we have ultrasound, which we all know that is the first line screening tool because it is widely available, it is portable, and no ionizing radiations are used. But it has some limitations. It has very limited acoustic windows, especially in people who are obese. CT is also widely available, rapid turnaround, superior fat and calcium detection, but again, the use of ionizing radiations and iodinated contrast material limits its role, especially in people who have end organ damage. MRI has very high soft tissue characterization, very good spatial resolution, but the time of examination is very long, and also it is contraindicated in people who are claustrophobic and obese due to its small bore diameter. Then we have nuclear medicine. It has very great physiological assessment, but very limited anatomic assessment. Lastly, we have DEXA. DEXA has low radiation exposure, inexpensive, short imaging time, but the subcutaneous adipose tissue and visceral adipose tissue discrimination is very limited. So now that we have discussed the modalities which can be used, let's discuss what are the techniques for fat quantification using these modalities. So there are mainly 3 fat quantification techniques. First is subcutaneous and visceral adipose tissue. We all know that adipose tissue is an endocrine organ and it is broadly classified into brown tissue and white tissue. So brown adipose tissue has primary role in thermogenesis in infants, and it works on the principle of FDG uptake. Next, we have white tissue. White tissue has primary role in energy storage in the form of subcutaneous and visceral adipose tissue, bone marrow, and perivascular fat. Ectopic fat is also the fat accumulation in tissues without the adipose tissue storage capacity. Its location can be around the kidneys, heart, or vessels in perirenal, pericardial, or perivascular form. Third is myosteatosis. Myosteatosis is the intramyocellular lipids which is linked to insulin resistance, and it is quantified by FDG PET CT or MR spectroscopy. So these images show subcutaneous and visceral fat segmentation. So what we do is we calculate the volume of fat and multiply it with section thickness to get fat segmentation. Here you can see that the visceral fat is the visceral fat is represented by green and the subcutaneous fat is represented by blue. Next is again a very simple technique. These are grayscale ultrasound images and they are showing how we estimate the intra-abdominal thickness and abdominal fat index. So what we do is on intra-abdominal thickness, we measure the subcutaneous fat thickness, which is the distance from the skin to linea alba, and visceral fat thickness, which is the distance from linea alba to vertebral body, and we add them. This easily gives us the intra-abdominal thickness. On image B, we are calculating abdominal fat index, which is again the ratio of subcutaneous fat, which is the distance from the skin to linea alba, and the preperitoneal fat, which is the distance from linea alba to peritoneum. These are FDG PET and CT images which show increased FDG uptake in brown adipose tissue in supraclavicular and axillary region. I have just added these slides so that you know how we assess brown adipose tissue on a nuclear study. So this table summarizes how metabolic syndrome affects different organs, the complications it causes, and how imaging plays a key role in detecting and managing these complications, even before the clinical symptoms appear. So we will discuss all these complications in detail in subsequent slides. So heart and vessels are earliest target. Cardiac complications include subclinical to symptomatic coronary artery diseases, myocardial infarction, heart failure, arrhythmia. So what we do on imaging is on non-contrast CT, we quantify the coronary artery calcification. On coronary CTA, we detect high-risk plaque and stenosis. On cardiac MRI, we assess structure and function of myocardium and differentiate ischemia from infarction or non-viability. On SPECT and PET study, we study the perfusion imaging. This is an axial view of CT which is showing pericardial fat layer. So this is a simple method to show you how we calculate fat around the heart on CT. You can see that the epicardial fat layer, which is between the myocardium and visceral pericardial layer, is highlighted in yellow, and the pericardial fat layer, which is external to pericardium, is highlighted in blue. This is PET myocardial scan and showing decreased perfusion in apical and anterolateral region of left ventricle. So you can see that we have a cold effect on stress imaging, but the cold effect is not retained on the rest imaging. So this finding is consistent with myocardial ischemia, not infarction. In infarction, we will have a cold effect on rest images as well. So grayscale ultrasound images of carotid artery is showing mild posterior thickening of vessel, which is consistent with arterial stiffness, and it is caused by dysregulated adipocyte factor. So vascular complications present in the form of chronic inflammation. In continuation of vascular complications, next we have a cardiac MRI, which has an inbuilt 4D pulse wave velocity measurement software. So it measures shear stress and pressure gradients and different part of aorta, like in arch, root, ascending or descending aorta. And what it does is it makes a graph out of these values. And with the help of this graph, we assess the accelerated atherosclerosis and high risk plaque formation. So it is just an inbuilt software in cardiac MRI. Other than heart and vascular complications, we have hepatic complications that involve a very broad spectrum from non-alcoholic fatty liver disease to hepatocellular carcinoma. What we do on imaging, on ultrasound, we detect steatosis, elastography for fibrosis, and on CT, we see the hepatic splenic attenuation, which is less than 0.8. On MRI, we see the quantitative and qualitative steatosis assessment, and MRI elastography, we see the high accuracy of, it has very high accuracy for fibrosis. These are the images which are showing the ultrasound assessment of hepatic steatosis. In the image A, you can see that the margins of liver are well visualized, and also the wall of portal vein is echogenic. Liver is also hyper attenuating than the right kidney. So this shows that this is the case of mild steatosis. However, in the image B, you can see that the margin of liver in comparison with the image A is not very well visualized, and also the echogenic walls are not retained. So this is the case of progressive steatosis. Again, this is the qualitative MRI hepatic steatosis assessment, and you can see that the first one is the in-phase MRI image, and you can see that on in-phase MRI image, the fat is supposed to be brighter than the rest of the parenchyma. So you can see that the attenuation of liver is brighter as compared to spleen. Similarly, on outphase image, the fat is supposed to be darker. So you can see that the liver is darker. It is hypoattenuating as compared to spleen. Again, this is the fat only sequence, and you can see that the liver is hyperattenuating than the spleen. So these findings are consistent with hepatic steatosis. These are B-mode grayscale ultrasound images through the liver, and showing how we measure liver stiffness using shear wave elastography technique. So what we do is we select a region of interest like this, and then we calculate the pressure at different points. Next, we have pancreatic, renal, and neurological complication that represent in the form of non-alcoholic fatty pancreatic disease, which is linked to insulin resistance and adenocarcinoma. Renal impairment, whose risk increases up to 50% in metabolic syndrome, and neurological dysfunction, which includes cognitive decline, ischemic stroke, peripheral neuropathy, etc. So these images are consistent with non-alcoholic fatty pancreatic disease. Here you can see in the first image, you can see there is a very diffusely increased echogenicity of the pancreas, and in the next CT image you can see that there is diffusely interspersed microscopic fat between the pancreatic lobules. So image C and D are in-phase and out-phase images of MRI, and again you can see that on the out-phase images the fat is darker as compared to in-phase images. So these findings are indicative of NAFPT. So lastly, we have gastrointestinal and gynecological complications, and these are grayscale images of pelvis showing ovary with multiple peripheral follicles, and you can also see that the volume of ovaries are also greater than 10. This is the ovary, and you can see that the peripherally arranged follicles in the ovary. Similarly, on the MRI images, you can see both the ovaries and the peripherally arranged follicles. So these findings meet the criteria of PCOS, polycystic ovarian syndrome morphology. So what is the take-home message? Take-home message is simple. Metabolic syndrome is not a disease itself, but it's a warning sign. It is a red flag. So it is major health issue with multi-system complications, but it is preventable, it is reversible. So multimodality imaging enhances the efficiency of risk stratification and enables us for opportunistic screening. So these are the references for this presentation. Thank you.